אז תרצו לי להציג, וכבוד הוא לנו להציג את דוקטור יוני אשחר, שהוא ישראלי לשעבר שגר בארצות הברית, חי בארצות הברית, והוא בעצם, הוא משתתף במחקרים הגדולים בשנים האחרונות, שממש עשו פריצת דרך בעולם הבנת הכאב. הוא הרבה עיתונים רציניים כמו ג'אמה, והוא בעצם אסיסטנט פרופסור, נכון? מה אתה, אולי אתה תציג את עצמך קצת יותר טוב, אסיסטנט פרופסור באיזה יוניברסיטי?
קולורדו,
קולורדו יוניברסיטי, והוא כן. ואתה תספר לנו איך הגעת לזה, כי יש לנו הרבה זמן, איך בכלל הגעת לכל התחום הזה, הוא לא רופא, הוא PhD, נכון? הוא יספר לנו.
נכון.
אז תהנו מהערב, והוא יעבור לאנגלית, כי זה השפה שהוא שולט ביותר.
נכון. אני לא, לדייק, אני לא, ההורים שלי ישראלים לשעבר, הם עדיין ישראלים, אף פעם לא, they'll never stop being Israeli, הם גרים בארצות הברית, אני גדלתי בבית ישראלי בארצות הברית, וגם חייתי בארץ כמה שנים, אבל I'm American, ולפני שמתחילים פשוט להגיד שאנחנו, כל המחשבות ותפילות שלנו, למצב בארץ, לחטופים, מקווים לשלום המדינה וחדשות טובות. So it's, it's heavy on all of us here in Colorado. It's far away, but close in our thoughts and hearts. So. נשמח לקבל כל השיחה בסוף ושאלות בעברית, but I'll switch to English for the conversation, for the presentation. איך הגעתי לזה? וואו, זו שאלה מורכבת וארוכה. I don't know, the short version is that מאוד התעניינתי במדיטציה, ואיך שמדיטציה משפיעה על פעילות המוח, ודרך זה נכנסתי ל-placebo effects, because the placebo is the power of the belief to relieve pain, and from there into mind-body healing, and so my background's in clinical psychology and neuroscience. עשיתי דוקטורט במעבדה בקולורדו, איפה שפאבל, דוקטור גולדסטיין, כאן עשה את הפוסט-דוק שלו, שאנחנו חברים טובים מימים האלו. אז אני גם מטפל בחולי כאב, as a clinical psychologist, אבל העיקר מה שאני עושה עכשיו זה מחקרים. אוקיי, ואולי נסתפק בזה, but there's a whole long story there too. All right. בואו נדבר על החלמה כאב. I love the title for this conversation because החלמה really means healing and recovery. נכון? That's what החלמה means. And that's actually a conversation I think we need to be having. Because the standard approach that chronic pain is a chronic condition that you have to learn how to live. Like diabetes. You don't recover from diabetes. You don't have to move from pain management to החלמה מכאב. לפני שאנחנו מתחילים, some conflicts of interest. I help these organizations with chronic pain. Okay. והרבה מהמספרים שלי הם בארצות הברית, so you'll have to, translate them to Israeli. But here in the US, we spend a huge amount on chronic pain care and days lost of work. It's more than the cost of heart disease and cancer combined. And yet, the problem is only getting worse. If you look at prevalence rates of pain across men and women across all the ages, the numbers are just going up and up and up. And so if we step back for a minute and just look at this picture, we have to say that, the house is on fire. We have a major problem. We're throwing tons of money at it and it's just getting worse and worse. So something is fundamentally off and wrong in how we are dealing with chronic pain. And I think the fundamental issue is that we are hyper-focused on the peripheral tissue, meaning the body, not, body, below the neck factors, in trying to think about and treat chronic pain. We're focused on things below the neck. And yet, we know that all these kind of changes throughout the body that we used to think were the cause of chronic pain are highly prevalent in people who have no pain at all. So, here's some numbers. 87% of pain-free necks have bulging discs. 72% of pain-free shoulder pain-free shoulders have superior labral tears. 97% of knees will show some kind of abnormality on an X-ray or MRI. So the range of the range of normal is really wide. Tons of people who have no pain whatsoever have all kinds of these changes, but these changes are just part of normal and healthy aging. And they're often not the cause of pain. They're what we call an incidental finding. You might see it on MRI or X-ray, but it has absolutely nothing to do with the pain. It's not the cause of pain. And yet this kind of approach has dominated how we try to think about and treat chronic pain. So what happens when we try to treat these to help chronic pain? So surgeries and procedures, at least here in the US, are quite common for chronic pain. How do you know if a surgery or a procedure is, really doing what it's supposed to do, if it's effective for chronic pain? What kind of control condition would you want to compare a surgery to? I'd love if people want to just, I don't know, come off mute and say, what would you want to compare surgery to know if it was effective? If anyone has any thoughts or ideas, if you're designing a study.
Sham surgery.
Sham surgery. Thank you, Leo. You want to compare it to a sham surgery. Okay, what is a sham surgery, a fake surgery? Basically, you put the person under anesthesia, if it's that kind of surgery. You make a superficial incision just on the skin. You sew them back up, wake them up and say, Mazel tov, you either got the real surgery or the fake one. There's no way to know. Just tell us how you feel. Or if it's an arthroscopic surgery, you basically go in with the tools, just wiggle them around and pull out. But the person doesn't know the difference. So what you do is you create the illusion of surgery. How effective is this? What happens when we compare real surgery to illusion of surgery? The largest study to date that I'm aware of is this one, chronic shoulder pain. People got the real surgery. In this case, it was a subacromial decompression of the tissue that was thought to be impinging on the nerve, versus arthroscopy only. So here they go in with the arthroscopic tools, they decompress the tissue. Here they just go in with the tools, wiggle around, make some funny noises and pull out. And they also have a no treatment condition. And here are the results. Again, 300 some folks. Higher is better here. This is the Oxford shoulder scale. Higher is better. And what they found here was really absolutely no difference between the real and this fake surgery for the shoulder pain. Now, they both of these real and fake surgeries did better than no treatment. So if you're a doctor in the study, or if you're a patient in the study, you would see people getting better with the surgery compared to doing nothing. But it's not happening for the reasons we think. It has absolutely nothing to do with the decompression of the tissue and everything to do with the illusion of surgery. You might think, okay, very nice, that's just one study. Well, okay, here's another study. This is steroid injection into the knee for chronic knee pain. They compared it to a placebo injection, so just salt water. One of these lines, this is a pain score, lower is better. One of these lines is steroid. One of these lines is salt water, mei melach, into the knee. And it doesn't matter which is which because there's absolutely no difference between steroid and placebo. What's nice about this study is they also used ultrasound to measure the thickness of cartilage in the knee. And what they found was that the steroid group lost more cartilage, which they thought was because the steroid is eating away the cartilage. So if you're in this study, you would rather be in the placebo group because you have the same outcomes and you get to keep your cartilage. So I brought here two studies, but actually this is the most common finding. Here's a meta-analysis, 15 trials, real versus fake surgery. The real surgery, there's no statistically significant difference between real and fake surgery for chronic pain. Real surgery does a bit better, but it's not significant even with 1,500 patients. So it's not that these surgeries, procedures don't work. They do work in the sense of people get better, but the way they work is by engaging the brain because their effect is completely or almost completely due to the illusion, to the placebo effect. right? The belief that you're getting surgery, the feeling, the sense that your body's getting fixed, that someone is caring for you, your hopes for recovery, all of that, and has almost nothing to do with the surgery or the procedure. I just also did a deep dive on radio frequency ablation of the basolateral vertebral nerve for back pain, no different from sham ablation. Pretty much every surgery I've looked into where there's good data comparing it to sham surgery, it's very hard to find a difference for chronic pain specifically. And if you know an exception, please, send me the papers. I'd love to see an exception to that rule. So these surgeries work by engaging the brain. It's the placebo effect. It's a very, very powerful placebo, right? The belief that you're getting a surgery is a very powerful placebo. So what do we know about chronic pain in the brain, if that's how these surgeries really work? Well, the short answer is that it's complicated. It's very complicated. There is, pain is processed in distributed networks across multiple regions, across cortex, subcortex, brainstem. There's no dedicated part of the brain just for pain. Like we have a visual cortex back here, auditory cortex here. There's no one place for pain. It's kind of everywhere and nowhere. And in chronic pain, we see changes all across those systems. I'm highlighting some of the changes here. But the main point to know is that it's quite complicated, and that actually may be part of the problem. That because with complexity, there can be errors in processing and mistakes. I'm going to highlight one specific brain study that for me was revelatory, really revealing. So this was conducted from the lab of Vanya Apkarian, Northwestern University. They recruited folks who had recently hurt their back. So 12 weeks after an injury, maybe they're moving, maybe they're doing yoga and they pull their back, and they brought them in to the scanner and they scanned their brains and they looked for the brain areas that were associated with their chronic back pain. So this is using functional MRI. It's a tool I use in my research as well. And basically the red here represents brain areas that are more activated for chronic pain. And what they found here was that chronic back pain was associated with the anterior cingulate, the thalamus, the insula. And if you were a pain neuroscientist, you would say, boring. This is exactly what you expect. These are pain processing regions. Nothing special whatsoever. Okay, fine. Now, what's special in the study is they followed people for a year. Now, a year later, half of them recovered from chronic pain, right? Their back got better. It hurt for a few weeks, a few months, but now it's better. And the other half of the people developed chronic back pain. As a year out, 1 year later, and the back still hurts. And when they brought these people back into the brain scanner, they saw something really remarkable. Whoops. They saw something really remarkable. What they saw here was now a different set of brain regions were tracking chronic back pain. What you see here is the medial prefrontal cortex, also shown on the axial slice here. And what you see here and here is the amygdala. And if you look in the if you look right here, right after the injury, a few months after the injury, there's no amygdala, right? There's no MPFC. You don't see it here. So the pain shifted to a different set of brain regions. And these brain regions, the MPFC, the medial prefrontal cortex, and the amygdala, are brain regions that are related to meaning making, learning, emotion. You could say storytelling. These are storytelling brain regions that tell the story of the pain. And the really provocative idea emerging from this study is that once the pain has shifted to these brain regions, it can live on loop in the brain, meaning the body can have healed. The body probably healed sometime in this window of 19 weeks or so. The body is healed, but the pain has now shifted, and because of these shifts, the pain is continuing. The person's continuing to feel pain, even though the injury has likely healed because of these shifts in the brain. So when pain transitions from acute to chronic, it shifts to learning and meaning related brain regions. And really what this means is that if we want to treat chronic pain, well, we want to target the brain and target these brain regions. And by the way, the MPFC is one of the regions that's engaged by placebos. So you could say placebos could be actually, a good treatment for chronic pain, though we know it's not as effective as we would like. So we need something better. So this work and other work has caused us to really step back and ask, well, what is pain anyways? מה כאב? The old view, going back to Descartes, Descartes talked about church bells. So pain is like when your foot touches the fire. Imagine someone is holding the rope of a church bell and they're pulling on the rope, and then the bell starts to ding up in the brain. Right? That's how we imagined. And the nice thing about that metaphor, it's one-to-one. Someone's pulling the rope, the bell is ringing. If someone's not pulling the rope, the bell is not ringing. And what pulling the rope means is that there is some injury or problem in the body. And in that old view, pain is a direct representation, a direct readout of the problems in the body, if there are, what the problems are, how injured the body is, right? Pain reflects how injured your body is. If you have pain, your body's injured. If you don't have pain, your body's not injured. Okay, that's the old view. It does not stand up. There's so much evidence showing that pain is just far, far more complex than that. So what's the new view? How do we understand what pain really is if we've gotten further than Descartes? So I'm going to share two ideas here that have been very influential for me in my thinking about pain. So one is that pain is a learning signal for guiding behavior. So when an organism moves through the world, they're trying to find, okay, where's the reward and where's the threat? And to do that effectively, you have to learn and you have to be predictive. So if your threat system was only responding, like a lion in the bushes, like you only start to process a threat after the lion has bit your arm, right? Too late, you're dead. You have to predict where the threat is. And if there's a prediction of threat, the brain can create pain to warn you, watch out, there's a threat coming your way. The idea here is that pain is really your and this comes from a learning history. So you touch the hot stove once and it hurts. The purpose of that pain is to teach you not to do it again. So pain is your teacher. So imagine, you hurt your back, you start to bend over, your back hurts when you bend over. Now your brain says, aha, I've learned something. Bending over is bad for me. Okay, I won't do that again. Right? And now that learning has happened, and it could be that next time, a month later, you start to bend over and your brain says, I'm smart. I know what is going to happen here. Let me create some pain to warn Yoni not to bend over because it's going to be bad. And so that starts becoming a very predictive process, a guess about where the threat is and a guess about, what's going to be dangerous. But sometimes those guesses can be wrong. The back could have fully healed and bending over is no longer dangerous, but the brain is still holding on to its own learning. Its old learning, what it learned in the past. The other really related idea here is that pain is an inference, meaning a guess. It's a guess about the current injury state. So the brain doesn't actually know the ground truth about whether the body is injured. The brain is just getting signals. And it's trying to guess based on those signals if there's an injury or not. It doesn't really know what, so it's going to take input from the body. It's going to take its prior beliefs. It's going to take what it sees to try to help it figure out, am I injured or am I not injured? Because I don't know. What I think about here is a kid on the playground. The kid falls on the playground. What's the first thing they do? They look for Ima or Abba. Be like, how bad is it? Right? Because the kid doesn't know. The kid's brain is like, there's a lot of sensations here. This might be bad. I'm not really sure. Ima, Abba, tell me, is it bad or not? Our brains are really not so different. We're trying to figure out, how bad is it? Am I injured? Am I not injured? We don't really know. We're just trying to guess based on that. And if we have beliefs that we're injured, then that's going to bias the interpretation of all the input from the body. Okay, so Bekitsu, the brain is doing a lot of guesswork, and it can be mistaken. It's trying to guess, is this thing going to be bad for me? This thing I might do in the future, that I'm about to do, is this going to be bad for me? Am I injured? Am I not injured? It's doing all this guesswork, and it can be mistaken, meaning the body can be healthy and healed, and yet the brain can be generating pain. And in this case, the pain's a false alarm, you would say. Right? There really is pain, but there really is no injury in the body. So it's a false alarm. Hazakat shav. So here we have to talk about subtypes, because this is not true for all chronic pain. This is true for some chronic pain. So a subtype is like, a sug shel chronic pain, a tipus, I don't know exactly. So the ICD-11, now I guess you all are probably using still ICD-10. I'm guessing most people are, or so, but
I think we use 11, don't we?
Use 11? Wonderful. Okay, in the US, most systems I talk to are still on 10. So the ICD-11 has this new distinction, which is amazing. It does not exist in any prior version of the ICD, and it's really a major advance. It talks about primary versus secondary pain. Are these familiar terms to anyone? Is anyone diagnosing people with primary or secondary pain in ICD-11? No, we don't. And put it in the chat if you are. I'd love to know if people are using these terms or in their practice. Okay, what are these terms? So secondary pain is pain that is secondary to some problem in your body. Like you have diabetic neuropathy, or you have a tumor or a fracture, and the pain is secondary. The pain is due to that. In primary pain, the pain is the primary problem. There is nothing underlying the pain that we can treat. The pain is the pain is the pain. We're here to treat the pain. There's nothing besides, there's nothing under the pain. This is it. It's the pain, and we're here to treat the pain. And this kind of pain is basically, it's driven by the brain, by sensitization and brain circuits. Another distinction we'll often see, this is the International Association for the Study of Pain. In research, we use these distinctions in nociceptive and neuropathic, which are basically secondary pain, or nociplastic, which means, plasticity in the pain processing circuits are causing the pain. With my patients, I use the term neuroplastic. I find that's like a nice, patient-friendly term, neuroplastic, plasticity in the brain. Okay, so these are categorical. Really, I like to think about it as a spectrum. The chronic pain being driven either by something in the periphery of the body, some kind of injury or pathology in the body, versus the central nervous system. People can be anywhere along this spectrum, and people can move. So soon after an injury, right? Soon after the injury is driving the pain, but now it's 5 years later, right? The injury is healed, and what's driving the pain is really changes in the central nervous system. And so what I'll be talking about for the rest of my talk, and I know several of the talks tomorrow, what we'll really be focused on is this side of the spectrum, right? Primary pain, nociplastic pain, centralized pain, neuroplastic pain. There's many different terms for this. But this is the subtype, and this step of subtyping is so important to get the diagnosis clear. What am I dealing with? Is the pain due to the bulging disc, or is it due to the brain? Because I know the bulging disc, many people have bulging disc and don't have pain. So is that really the cause, or is it the brain? All right. So how do we know if someone has primary pain or not? I'm going to share a clinical approach. This was developed by a number of folks, but most importantly, or I don't know, Dr. Howard Schubiner has done a lot of really important work helping develop this method. So we don't have time for we could talk for an hour about just how to diagnose, at least an hour, more like 4 hours, just how to diagnose, but I'm going to give a very brief overview. So step one is you rule out any clear pathology cause. Has there been unexpected, substantial weight loss, any of the, red flags that you might see, any signs of infection or anything like that. And then what I want to focus on really is more the rule-in criteria. So what are some indicators, positive indicators, that if you see this, it becomes more and more likely you're dealing with primary pain or neuroplastic pain? So one is when the pain onset is during life stress. I had a patient tell me recently her back pain started the day before her wedding. I said, okay, very interesting. Did you have a fall the day before your wedding? Nope. Did you have any injuries the day before your wedding? Nope. Do you think there's any connection to your wedding? Oh, gee, I never thought about that, right? This is a sign. When something big or emotionally, big or stressful is happening, our brain is primed to learn about threats. Our brain is ready to learn about threats. So it's a great moment to develop chronic pain. When symptoms move or spread over time, so, the pain started on my shoulder, but now it's moved down my arm. Generally, injuries don't spread, injuries don't move. But the brain sensitization can cause the spreading of sensation. Oh, the pain, sometimes it's on the right, sometimes it's on the left. Well, the injury is not bouncing back and forth between left and right, but the brain can cause symptoms to be easily mirrored to both sides of the body. Inconsistent pain behavior. My back hurts when I walk on concrete, but not when I walk on wood. Does that make sense from any kind of biomechanical perspective? Right? Not really. So these sorts of clues, you have to really, look for these kind of clues. My back hurts when I sit in certain chairs, but not other kinds of chairs. I don't know, right? Come on, really? Family history of chronic pain. It's a particularly diverse chronic. No, my mom had headaches. My dad had stomach problems, but the doctors could never figure it out. My sister has hip pain, and I have shoulder pain. Right? This is probably what's shared among the family members as a genetic predisposition to, sensitization of brain circuits. Yeah, right. We have history of multiple pain conditions as well, right? My stomach, I had, tummy, my stomach hurt when I was a kid. In college, I had back pain. Now I have headaches. Right? What are the chances that they have some kind of GI condition, a stomach condition, and then some spinal condition, and also some kind of neurological condition driving the headaches? Much more likely is a sensitized pain system that's causing symptoms all over the body. When you see a body map that looks like this, you're starting to really think primary pain. All right. So how common is primary pain? I'm going to poll you in a moment, but let me tell you about a study we did. We went down to a clinic in Louisiana. It's a state here in America. It was a spine and neck clinic, community clinic, and did a complete assessment on 222 consecutive patients. So just next person to walk in the door, 222 people, try to assess them. So I'd love to see some, maybe put in the chat. What do you think? What percentage was primary pain? Or come off mic if you want to just say, take a guess. What percentage of these 222 is primary pain? Back and neck. Back.
64.
64, not 63, but 64.
Mm-hmm. Yeah. 10%.
10%. Great. So we have a big range here. 90, we have some people guessing 90, some people guessing 10. This is good. So we're all different starting places. But it seems like a lot, there's a range. Some people think it's most, some people think it's, a small number. Okay, so this might be my most provocative slide. See what you think. But what we found was 88% was primary pain. 6% was mixed, meaning, yes, there's a bodily cause and the pain is really disproportionate to what you'd expect. So there's both. And 6% was secondary pain. The pain is clearly due to an issue in the body. So this is a very high number, right? And you may disagree with it. You may say, no, I don't, that's too high. to which I would say, well, I kind of agree in that, we don't have objective validated measures to figure out what's the cause of a patient's pain. We might see something on the X-ray or MRI, and do we know that's the cause? No, we know it's there, but is it the cause of the pain? We don't know. We could use this clinical method that I've, a little bit outlined in the previous slide, and is that 100% validated? Nope. So there's still an open question. And but my takeaway is that the rate is a lot higher than I would have thought, and probably the majority of back and neck pain, but it's still an open question. We're trying to figure this out. Okay, so when pain is primary, meaning it's neuroplastic, can it be resolved by psychological treatment? And what I mean by the word resolved is החלמה. People say, I don't have back pain anymore. אין לי, הגב לא כואב לי כבר, זהו. Right? I'm not saying like my pain's a bit better. Yeah, as זה עזר, I'm except, מסתדר יותר טוב. Like, no, כבר אין לי. So what do you all think? Can it be resolved? If the pain is neuroplastic, can you send someone to a psychologist and have them, resolve the pain? I'd love to get a few more, voices or chats, what people think, I say, can that happen reliably? Not like the bimikre, like 1 in 100, but can you resolve chronic pain with a psychological treatment?
Maybe very low chances.
Maybe very low chances. Only a few cases.
Very low chances.
Nachon.
Maybe biofeedback.
Maybe biofeedback. I think that's what I heard. Okay. So
biofeedback is not psychological.
Thanks, Ronit. You're stealing my thunder. Ronit's going where I'm going. Okay, so there's a range of opinions. Some people are like, oh yeah, and some people are like, nah, not really. So I would say that if you look at the research, you have to agree with the people like, so I can't tell the names, but you have to agree with the people who say not really, maybe a very low chances. Because let's look at the data. Let's look at, our leading psychological treatments. And they typically provide a pre to post reduction of 1.5 points. Okay, this is not recovery from pain. This is, my pain's a bit better. I'm just going to show you, here's data from one recent really large study conducted by some of my colleagues, right? Over 500 patients treated with 3 different leading psychological treatments. We have MBSR, mindfulness-based stress reduction. We have cognitive therapy, behavioral therapy. Okay, these are some of the most evidence-based treatments, and patients, large study, patients go from around, 5.5 to a, 4.5, פחות או יותר, depending where you're looking at, right? There is no recovery. And החלמה, right? And החלמה, people are going down a bit, 1.5 points. Okay. So you have to be skeptical and say, like, no, I don't think psychological, maybe for a few people, but not really. And this is the launching point for, pain reprocessing therapy, which I'll talk about next, which is basically saying, can we do better? And PRT is really based on these kind of some of the limitations of these existing treatments. Now, one of the key things that these existing treatments don't do is they do not subtype people. For MBSR, cognitive therapy, behavioral therapy, pain is pain is pain is pain. I don't care if it's primary, I don't care if it's secondary, I don't care what's causing it. We're just going to deal with the pain. And that is a big, that's a big miss. So in PRT, which I'm going to briefly summarize here, and I can talk later more how it's similar or different from other treatments. The central model is that pain drives threat, and then threat then drives pain. The more you respond to pain with threat, the more your brain turns on the pain signals. Like there's danger here, and pain is your brain's opinion of how much threat there is. Bernard, you might want to unmute after you're talking. So what are the steps here in PRT? So first step, and this is different than other treatments, is assessment. Do you have primary pain? Do you have secondary pain? Right. There's a whole, usually, well, the way we do it, it's a 1 hour session trying to figure this out. Then there's personalized pain education, where we help the person understand that their body has healed and their pain is driven by the brain. So it's like, hey, you know how your pain started the day before your wedding and has spread to different parts of your body. And it behaves in these really inconsistent ways. It only hurts when you walk on concrete, but not on wood. Those are all really strong indicators that this is, neuroplastic pain. And we help people map it onto their own life, understand this is me. And then a series of techniques for learning that the pain is safe. These are cognitive and somatic and exposure-based techniques. Basically learn that the pain is a hazakat shav. It's a false alarm. Your body's healthy. There's nothing to be afraid of. And we have some specific techniques for supporting that learning. And then the fourth step here is dealing with what we call non-pain threats. This is stress, emotion, trauma history, all the complicated stuff that's not directly linked to it's not the pain itself, but it's part of the pain system that we also try to treat in PRT, like emotional functioning and more. Okay, this is a very brief summary. So the first clinical trial of PRT, 151 back pain patients recruited from Colorado, where I live. The paper is published 2 years ago now in JAMA Psychiatry. Please look it up, read the paper. And here PRT was delivered in 9 sessions over 1 month. This was 1 session with a physician who did the diagnosis, followed by 8 sessions with a therapist who delivered the treatment techniques. Patients came in for a brain scan, blood draw, and patient-reported outcomes. They were randomized to one of 3 groups. Usual care, keep doing what you usually do for your back, placebo injection, or pain reprocessing therapy, and they returned a month later for an identical assessment session. Let's look at the outcomes. So the primary outcome here was pain intensity. And in the usual care group, people started around a 4, they went down to about a 3. Okay, and they stayed there for 1 year after. So treatment ends right here is post-treatment. This is where treatment ends. We follow them for 1 year. Placebo group actually, had some improvements at post-treatment. This is a significant interaction, but the benefits weren't really maintained for 1 year. And in the PRT group, people went from about a 4 to about a 1, and mostly stayed around a 1, 1.5 for 1 year post-treatment. The effect sizes that we saw here, Hedges G, it's like Cohen's D, were really much larger than have been previously reported in the literature, and very amazing and encouraging. And I can tell you, when I first saw the data, I was astonished, completely astonished to see this kind of response. Same data from a different perspective. Each dot here is 1 person in the study. So, and if you're above this dashed line, your pain got worse. If you're below it, your pain got better. So usual care group, some people got worse, some people stayed the same, some people got better. Placebo, okay, looks a bit better. There's a placebo response. It's not big, but it's there. And in the PRT group, nobody got worse. 1 person stayed the same, and everyone else got better. But what was really remarkable was this group of people reporting a 100% symptom reduction. This cluster of people saying, I don't have, 100% symptom reduction. So we operationalized this as people reporting 0 or 1 out of 10 pain at post-treatment, and 2/3 in the PRT group were we say pain-free or nearly pain-free, 0 or 1 of 10 pain, compared to 20 and 10% in the control groups. And at 1 year, about half remained pain-free or nearly so. The numbers are great, but I want you to hear it in the words of participants in our study. So these are two folks that were in our study reflecting on their experience.
I can honestly say I have 0 back pain right now. It's drastically different. I think I was 7, 8, 9, when I came in.
18 years. And it never stopped hurting for 18 years. I'm I don't have any. I'm pain-free. It's amazing. I can't believe I'm saying it, but it's true.
So just to emphasize, this is a 9-session psychological treatment, and people are saying, I don't have pain anymore. Gav כבר לא כואב. How did this work? Right, it can't be magic. How does this work? I'm going to talk about 2 mechanisms, manginot. So one is reduced harm beliefs and activity avoidance. We use this wonderful measure, Tampa Scale of Kinesiophobia, that asks questions like, pain always means I have injured my body. I'm afraid I might injure myself if I exercise. So zebidyuk, the beliefs, the emunot, the deot, that PRT is trying to change. And what we found is that the more people reduced these beliefs, the more their pain went down in the placebo group. So in the PRT group. So shown here in blue. The more they reduced these beliefs, these harm beliefs and activity avoidance, the more their pain went down. And we have a patient, Nivdak B'Mifkar, that just says it perfectly.
So the pain now, when I do get some pain, back pain, I'm more like, bring it on, come on, bring it on. No, this is nothing, I'm not in any danger, I'm not afraid. If it stays, it stays. If it doesn't, great, but it doesn't intimidate me.
So I just love the fearlessness that you can tell. She is like, I don't care about the pain. I'm not afraid, right? Bringing down the fear is the main thing, bringing down the fear of the pain. Another key idea we're working with here is what we call a pain attribution. B'milim pshutim, it's just, what do you think is causing your pain? אנחנו שאלנו את הנבדקים במחקר, תגידו לנו במילים שלכם, מה אתם חושבים? What's the cause of your pain? מה גורם לכאב שלכם? And when we asked people these questions, we categorized their answers. And basically they told us things like it's mostly, activities, injuries, something physiological, like my muscles are weak, my muscles are tight, my mattress is too firm, my mattress is too soft, right? Very few people are thinking anything psychological, anything about the brain. Some people are thinking stress and dark green here, but very little. You stop someone with back pain on the street, you ask them, tell me what's causing your pain. They're not telling you it's my brain. Okay, that's pre-treatment. After treatment and placebo and usual care, there's really no changes in these beliefs. But in the PRT group, we saw large changes in these beliefs. Suddenly, our people who completed PRT are thinking psychologically and thinking about the brain. So now you ask these patients, tell me, what's the cause of your chronic back pain? And they say, neural pathways in my brain. It's fear and anxiety. It's my trauma, it's my trauma history, emotional trauma history. It's my marriage, my partner is abusive. That's what's the stress of the relationship. This is, how many of your patients, you ask them that question, are giving you some kind of psychological or brain-based response? What we found is the more people shifted to thinking about these causes of pain, the more their pain went down. Okay, so key findings of this work. So psychological treatment can resolve a substantial portion of primary chronic back pain, of neuroplastic chronic back pain. Yes, we can resolve it. Whether that's going to be like 2/3 in our study or 1/3, it's going to really depend on a lot of factors because response to psychological treatment is always variable. But it's possible. It's completely possible that you can, החלמה מכאב with a טיפול פסיכולוגי. I think 100% אפשרי. Now, how does this work? I talked about reduction in fear and avoidance of pain and changes in beliefs about the causes of pain. Some limitations of this work, in that study, the control condition was a placebo injection. It wasn't a great control. The sample was 89% white. The clinicians were experts. And forgot the bullet point here, but the sample was relatively well educated and highly functioning. And so we don't know the generalizability of, how much, if you go to a more severe patient population, how effective it is treatment. We're not sure. And we're currently conducting a study right now that's, addressing all these issues. We have about 50 people enrolled so far. So hang tight and we'll know in a year or so. All right, just basically a final slide or two. So what's the pain clinic of the future? When I think ahead, I think the subtyping issue is critical. We have to start, to treat pain effectively, we have to identify the underlying causes. And we have to create this bucket here that doesn't exist so much, not so clearly today. We can call it primary pain in the ICD-11, or we can call it neuroplastic pain, and distinguish this bucket from people with mixed or secondary pain. Again, this is, say likely the majority of chronic back pain, certainly fibromyalgia, most of headache and so forth, a lot of chronic pain conditions. When people have primary pain, we want to give them some kind of brain first treatment because that's the cause. So that's what you should treat also. Like PRT, like many other treatments, not many, but like several other treatments that are out there. And then if we have secondary pain, then yes, some more biomedical treatment aiming to address the issues in the body. And for mixed, you run an integrative approach. All right. Some PRT resources in Israel, if this is resonating, you have a patient you want to send this to. Painreprocessingtherapy.com, they have practitioners in Israel. Pavel, on this call, is running a lab, and he has some great resources here, including this new video they just released. I just saw it yesterday for the first time. That covers a lot of these ideas really beautifully, בעברית, in a very patient-friendly way. You can find this video on their website. Here's another Hebrew language website that has great resources as well. And I think from all the rest of today and tomorrow, there's a lot happening in Israel that I'm less aware of. So I think there's a lot of amazing resources out there. And this is just the tip of the iceberg. There's so much out there that you'll hear more about. So I'm guessing maybe 1 million Israelis with chronic pain. Mind and brain contributions are not adequately assessed or treated. We're not doing a good enough job, I think, in trying to really center, is this a mind or brain case, and can we treat it? And then, if we do accurately subtype people and give them a brain first, mind, psychological first treatment, can we have better outcomes? I think so. Thank you all for your attention. Thank you to our funders. I'm glad Yael gave me some extra time, and we